Good evening, everyone. My name is Courtney, and I am the Outreach Coordinator at Penn Medicine's Vassar Center for BRCA. On behalf of the Vassar Center's Black and BRCA initiative, I would like to thank you and welcome you to tonight's panel discussion, Empowering Generations, Have You Had the Family Cancer Talk? The Black and BRCA initiative is a collaboration between the Vassar Center for BRCA and its team of patient advocates, researchers, and healthcare professionals to bring tailored resources and support to the Black community. Black and BRCA seeks to empower individuals to understand their family health history and take action to prevent cancer from one generation to the next. The opinions and experiences shared tonight are the panelists' own and do not represent those of the Vassar Center or Penn Medicine. You should consult with your healthcare team, and should you have any questions about the specifics of your health and medical plan. Thank you to our panelists for joining us this evening for this important conversation about how to discuss family cancer history and the value of genetic counseling from the clinician perspective of Vassar Center oncologist Dr. Payal Shah and genetic counselor Tiffiney Carter, as well as the patient perspective of Ashley Dedmon, a member of the Vassar's Young Leadership Council. Erika Stallings, who will be moderating our panel this evening, is an attorney, writer, and patient advocate based in New York City. In 2014, she learned that she carried a BRCA2 mutation and underwent a preventative mastectomy later that year. Her experience, along with learning about racial disparities and access to an uptick in genetic counseling and testing, motivated her to become an advocate for increasing awareness of hereditary cancer in the Black community. Erika is founding co-chair of the Vassar Center's Young Leadership Council and our partner on the Black and BRCA initiative. And with that, I would like to turn it over to Erika.
Thank you so much, Courtney, for that great introduction. And thanks to everyone who is joining us this evening to help kick off National Black Family Cancer Week. This is the first year that the FDA has designated the week of June 17th. And we're really excited to do this panel to hopefully better educate all of you and give you some tools about how to have conversations about family health history and genetics. So I will really quickly introduce each of our panelists, and then we will get into our discussion. So first, we have Dr. Payal Shah, who is an assistant professor of medicine in the Division of Hematology and Oncology at the University of Pennsylvania. She is a medical oncologist and clinical researcher who specializes in breast cancer, ovarian cancer, and cancer genetics. With the support of the Vassar Center for BRCA, her research focus is on studying cancer risk and developing treatments, including targeted therapy and immunotherapy for patients with breast and ovarian cancer. Next, we have Tiffiney Carter, who is a who has been a board certified genetic counselor for 14 years with a particular affinity for cancer genetics. She currently manages the cancer genetics high-risk breast cancer assessment programs in the departments of medical oncology and breast surgery at Houston Methodist Sugar Land and Houston Methodist West in Houston, Texas. And finally, we have Ashley Dedmon, who is a native Houstonian and holds a Bachelor of Science degree in Community Health from Prairie View A&M University and a Master of Public Health from Florida A&M University. She is a certified health education specialist and actively volunteers as a cancer research advocate. Thank you all for agreeing to share your knowledge and expertise with the audience this evening. And I do just want to note there will be some time for question and answer after the panel, and you can type your questions into the chat feature directly. We'll try to get to as many of them as possible. So with that, I kind of want to kick us off and just set the stage. So Dr. Shah, could you explain actually when I say hereditary cancer, what is that and where does that fit in the overall landscape when we're talking about cancer diagnoses?
Yeah, so thank you for asking. I think it's really, first of all, thank you so much for inviting me to be on this panel. And I think it's so amazing that we're talking about this incredibly important topic. And it's very exciting to have National Black Cancer Family Cancer Awareness Week. So with regards to what we mean when we talk about hereditary cancer, so the vast majority of cancer is what we call sporadic. And what that means is that there's really not a great identifiable reason that it happened. It happened by chance, at random. There are probably some undefined environmental or genetic factors that might have contributed to a small degree, but for the most part, it's just happenstance. And that, again, is what we call sporadic breast cancer. The other end of the spectrum, we have hereditary breast cancer. And this is cancer that is linked to our genes, which are the genetic makeup that we inherit from our biological mom and dad. And so when we think about hereditary cancer, I think the most common one that we all think about is related to the BRCA1 and BRCA2 genes, also called the BRCA genes, which are related to hereditary breast and ovarian cancer. And they have been in the media a bit lately. And but there are multiple other genes and genetic factors, even outside of BRCA1 and 2, that can be linked to inherited or hereditary cancer.
Thank you. And I know we don't have time to cover all of those mutations, so I'll focus on BRCA1 and 2. So for individuals who carry those a BRCA1 or 2 mutation, what are we really talking about in terms of like the overall cancer risk? And are there other cancers beyond breast cancer that are associated with those mutations?
Yeah, that's a great question, and it's an important point to clarify. So breast cancer is certainly the cancer that we think about most commonly when we hear about BRCA1 and 2. So BRCA1 in a biological female is associated with a breast cancer risk of about 60 to 80%, and an ovarian cancer risk over the course of one's lifetime of 20 to 45%. There are also other cancer risks that we think about with BRCA1, including about a 2 to 3% risk of pancreas cancer, which sounds low, but is still higher than people who don't have a BRCA mutation. And then it's important to point out that there are risks for men too. So with a BRCA1 mutation, men have about a 1 to 5% lifetime risk of breast cancer and about the same risk of pancreas cancer, so 2 to 3%. For BRCA2 in a biological female, we think about breast cancer risks in the range of 50 to 70%, and ovarian cancer also being lower than BRCA1, so about 10 to 20%. And the pancreas cancer risk is about 3 to 5%, and we put melanoma risk in that same range. For biological males with BRCA2 mutations, the risks of cancer are a little bit higher with BRCA2 than BRCA1. So the lifetime risk of male breast cancer is around 5 to 10%. And there's actually also about a 15 to 25% lifetime risk of prostate cancer with the BRCA2 mutation. And the prostate cancers that we can see in males who have a BRCA2 mutation tend to be a little bit more aggressive and often diagnosed at a later stage. And men also carry the risks of melanoma and pancreas cancer around the same as women.
Got it. So those are some pretty high percentages that you threw out there. And one thing I want to talk about before we turn it over to Tiffany is first, we talk about racial disparities and we're focusing on, Black women, Black individuals. How big of an issue, kind of what does that landscape look like?
Yeah, so this is such an important question and an important discussion because we're talking more and more about disparities in cancer care. And we know that these disparities are real. They involve everything from recommendations for screening, recommendations for chemotherapy, recommendations for genetic testing, all the way to referrals for clinical trials, and actually also rates of death from breast cancer. So what we know is that patients who are Black who have breast cancer, they generally are diagnosed at a younger age. They are more likely to have hormone receptor negative or triple negative breast cancers, which can be more biologically aggressive. They're often diagnosed at a later stage. And by stage, we mean how big is the tumor, how many lymph nodes has it gone into, has it traveled outside of the breast and the lymph nodes. And disturbingly, Black women are about 40% more likely to die from breast cancer than white women in the United States, even though the actual overall incidence of breast cancer is about the same in both groups. We know that there are innumerable factors that contribute here. There are socioeconomic factors, probably biologic factors as well. Things like transportation, childcare, health insurance is a really big one. When we talk about clinical trial accrual, we're thinking about trust of the healthcare provider and the healthcare systems that we have. I honestly have had patients in clinic bring up Tuskegee and Henrietta Lacks with me. And so, I mean, I know that the focus of this discussion is mostly on having family discussions of genetic testing, but just because it's pretty timely, I want to mention some work that was presented at the national meeting, the American Society of Clinical Oncology meeting just a couple of weeks ago. So our Cancer Center Director, Bob Vonderheide, presented some work that was also spearheaded by Dr. Carmen Guerra here. And what they have noted, which has been noted elsewhere, is that in the United States, even though, Black people make up about 13% of the population, they make up only about 4 to 5% of patients enrolled in clinical trials in cancer. And this is obviously just reflective of a disparity that so many of us have intuitively felt for so long. And so what Dr. Vonderheide presented was that going out into the community and launching kind of a really proactive outreach programs involving going to churches, community centers, neighborhoods, wellness fairs that are attended by Black patients actually increased clinical trial accrual by a lot. And so, I mentioned this just to give an example of the strides forward that are being made. There are small strides forward that are being made. And I think, most of what I've just talked about, especially to everybody on this panel and probably to a lot of people in the audience, sounds just so intuitive that we've all kind of been around these disparities for so long. But I think what we're seeing in recent years is that we're now studying it. We're now attaching numbers to it. We're now bringing it to the podium at major national meetings and publishing it in major medical journals. And what this does is it gives it importance, and it also kind of lays the foundation for us to do something about it. So that was a long answer to your question, Erika.
No, that's okay. And actually, I do kind of a final question before we turn to Tiffany, is I believe there was another paper that just came out related to this question, which is, I know we're talking here about like family health history and genetics. In the Black population, is there an increased risk for BRCA mutations as compared to the general population?
Yeah, so this is another really important topic. It's been studied a lot, but definitely just a couple weeks ago, there was a really great paper published about this in JAMA, and the first author was the Vassar Center Executive Director, Dr. Domchek. And Dr. Domchek and colleagues looked at about 4,000 Black patients and about 25,000 white patients who had genetic testing. And when they looked at 12 different genes that are associated with cancer risk, they basically found that overall the incidence of finding what we call a pathogenic variant, which is the kind of mutation that increases your risk for cancer. The frequency of finding that kind of a mutation in Black patients was overall, about the same as finding a mutation in white patients. There were a couple of small differences. So, one gene called CHEK2, we know is more commonly altered in patients of European ancestry. And indeed, that one gene was there were more pathogenic variants in the CHEK2 gene in white patients than in Black patients. And Black patients had slightly higher prevalence of BRCA2 mutations and PALB2 mutations. But when you actually look at the differences, the numerical differences, they're so small. So really the bottom takeaway is that we're seeing these mutations in white patients, we're seeing them in Black patients. Race should not be a deciding factor when you're determining if someone needs genetic testing. We need to make sure that we're testing white patients and Black patients.
Thank you. And with that, I want to sort of transition. And I realized one thing that I kind of want to connect the dots for the audience a little bit, right? So we're talking about hereditary cancer. How do you know if you have a hereditary cancer syndrome? That's where our genetic counselor comes in. So Tiffany, I do kind of want to get started, I guess, for maybe someone who's unfamiliar with this, actually just giving a very brief description about what genetic counseling is, what happens during an appointment, and how should an individual prepare for that appointment.
Yes, thank you, Erika, and thank you all for inviting me to be on the panel this evening. I think this is an extremely important topic, as well as Dr. Shah said, and I'm so excited that you're addressing it and that people are interested in learning about this. So genetic counseling is actually an education process. It is an appointment where individuals come in and we discuss what their family history is, what their concerns are related to their cancer risk. We talk about how genes affect cancer risk, what genes are. We talk about genetic testing and how that may be helpful in their discovering what might be causing the increased risk in their family. We also discuss if they don't know their family history, how testing or how genetic counseling might be helpful for them in determining what their screening regimen should be related to different cancers that we know can potentially run in families. So it's essentially an appointment where individuals come in and we discuss any concerns they have around cancer, their personal risk, their family history risk. And what we ideally would like for them to bring in is if they do know their family history, we'd like to know the individuals who have been diagnosed in their families, what types of cancers they've been diagnosed with, at what ages, and if they're still living, what the treatment regimens were, if they have had genetic testing themselves, and if those results are available. If they have passed away, we would like to know the age of death. We would like to know the types of cancer that they had, where they were treated ideally, if those records are available. So as much information as they can provide to us is very helpful when we're trying to determine risk and also trying to determine coverage for insurance.
Got it. And I do want to say for people who are in the audience, the Bassar Center website, bassar.org, has a family health history tool that you can download if you are preparing for a genetic counseling appointment. But Tiffiney, one of the things I am really curious to ask you about, I have a lot of people who are thinking about genetic testing reach out to me. And one of the questions I get a lot is, what should someone do if there's someone in their family who's had cancer, but that person doesn't want to be tested? And then two, how do you think about genetic counseling and testing if you are unable to get all the access to your family history is incomplete?
So I think that this is a great question. And we know that some individuals are just not comfortable discussing their personal history, whether it be with family members or with other individuals. And so I think that it's important for us to show some understanding, show some empathy in those discussions. Of course, we want the information and we know that it is important to us, but at the same time, I think it's important to recognize where they're coming from as well. So I think that helps just setting the stage to be able to even discuss these things with them. And I think, secondly, I think that getting at those emotional kind of concerns or issues that they might have with discussing this information, because it is scary. I mean, if we really think about it, it can be scary learning about any health information or disclosing any kind of health information. And so just kind of showing that we understand that this is not an easy topic, but also relating it to wealth. I think that knowing this information is very wealthy in families. And it's very important that it's shared over time, because it really does afford the opportunity to have knowledge and potentially save lives, is the bottom line. And so being able to get at that maybe reason why this information doesn't want to be shared. But then also, I think it's important to, if you're having difficulty getting anywhere with them, is bringing in other family members into the discussion if you can. Sometimes other family members may have more influence over those individuals, and wanting to share, they're more willing to share that information with them. Or if there's a group of people around that this might impact, that can be power as well. So I think being able to bring in other individuals who might be able to talk with them and help them understand why this is important as well, and let them know that they're supported. Support goes a long way. And so I think that that's very important also, Erika.
Yeah. Well, actually, Ashley, I want to ask you to jump in for a second, because correct me if I'm wrong. I remember you told me you shared your information at a family reunion. So I'd love to hear a little bit more about, and we'll come back to maybe talking about what led you to discovering, your risk for hereditary cancer. But I wanted to ask you, because I remember you had such a great story about like how you shared your information with your family.
Absolutely. Good afternoon, everyone. And I want to first thank the Baxter Center and the Black BRCA initiative for creating this platform, for creating a safe place for this discussion, and for the opportunity to be a part of the conversation. So I did something really unique. Being an advocate, what I did was I had my preventative double mastectomy in December of 2016. And so my birthday is in October, and it's also Breast Cancer Awareness Month. So I used that time to have my mastectomy and birthday party. And so I brought together all of the women in my life, and I used this time to tell them about my journey, to tell them about my family history. And I shared with them the decade of increased surveillance that I had been doing to aggressively monitor my breast and ovarian health. And I also talked to them about my decision to have a bilateral prophylactic mastectomy, which would drastically reduce my risk down below to a 1% to 2% residual risk. I also had a genetic counselor friend of mine to come and talk with them about their family history. They talked with them about BRCA1 and BRCA2 and the cancers that are linked to them respectively, as well as talking to them about the importance of identifying the rare, young, and multiple cancers on both sides, on the maternal and the paternal side of their family. And they actually provided them with a risk assessment resource as well. And of course, we played games, and I really allowed my village just to love on me and pray for me right before I went into my surgery.
Got it. And actually, I feel really grateful, because actually, for anyone who's in the audience, what we actually have up here is a copy of Ashley's family history pedigree that she put together. But one of the things I wanted to ask you about, you've disclosed that you have a hereditary cancer risk, you underwent a preventative mastectomy. How did you actually get the information that we see up here on the screen? Like, what was that process like?
So I was very fortunate to have a really good genetic counselor who really did a good job with explaining everything to me. I also have a teaching background, science and health. And I really just did a lot of research. I asked a lot of questions, and I began to put that pedigree together. But before that happened, it started with having conversations with my family members and asking those questions on how did, my great grandmother die? How did my grandmother die? And of course, I knew how my mother had passed away. And so it was having those conversations on the front end with my family members and really digging deep. And a lot of times in the Black community, we have this, what happens in our home stays in our home. And we can no longer, when it comes to our family history, live by that. Because we need to be able to share with the next generation how grandmother, how aunt, how mother, how father, how uncle, how they died, so that that next generation, and even the same generation of family members can know. So as they're going to the doctors and they're having to share their family history, they're able to articulate and provide that information to their physicians, so they can have the right interventions and treatment that's appropriate.
And you mentioned earlier that you underwent a preventative mastectomy. And I just wanted to ask you, you got your family, you figured out your family history, you figured out you had this hereditary cancer risk, and sort of what were the drivers behind the decision that you ultimately made to have risk reducing surgery?
Absolutely. So I began seeing my high-risk oncologist at the age of 21, within months of receiving my genetic testing results. And the truth is, my mother had just passed away. My father was diagnosed, and I was hurt. I was grieving. I was in denial. I was scared. I was scared because I really saw myself dying from cancer. And so it was important that I really leaned into those feelings because they were valid and they were important. But I always kind of told myself, Ashley, you can't pitch a tent and camp here either. You have to do something about it. And so when I talked with my doctor at the age of 22, we began to have those collaborative bi-directional conversations. And I say bi-directional because it is important that not only my physician was talking, but I was talking with her as well. And so it was there, I talked with her about the importance of me starting a family, and I was wanting to breastfeed. And that's where she really talked to me about my options, which were increased surveillance, which would aggressively monitor my breast and ovarian health, hormone therapy, which would drastically reduce my risk of probably around 50%. And then of course, prophylactic procedures. And so at that age in my early 20s, I really felt that increased surveillance was the best for me. I felt empowered because I knew should something occur, that I was going to be able to catch it early. And then during those 10 years, I got married, I had my first baby, and I had a chance to breastfeed her, but life happened. And I really saw myself going down some of the same patterns as my mom. And that is not really putting my health as a priority. But the difference with me was I knew better because I knew I carried this mutation. And so after talking with my husband and talking with my doctor and really praying about it, that's when I went back and I explored those options to have a preventative double mastectomy. And knowing that I wanted to have more children, I had to really ask myself, would I be okay not breastfeeding any future babies that I have? And so, and then to date, on the other end of my mastectomy, I still receive my transvaginal ultrasounds. I now get CA-125 blood work to monitor my ovarian health, in addition to my annual clinical exams, and visiting my dermatologist for melanoma.
Got it. That's a lot. So Tiffany, I want to come back to you for a second, right? Because I often sometimes hear people, say, well, I don't want to undergo, genetic testing because I don't want to know about I don't want to know about this information, or maybe God's just gonna, work it out for me, right? Like I'm gonna pray about it. But let's say we have a patient who is not necessarily ready to go through the process of genetic testing, but is concerned about their risk because they know that, they've had a parent or family members who've been diagnosed with cancer. what are sort of the options or paths for that type of individual?
Yeah, so I think that sometimes we think that we have to jump to the test because it's going to give us all the answers, but not necessarily. We can go at a slower pace, definitely, that's more comfortable for patients. And so I think one of the things that we can do when you're coming in for your appointment is we can do risk assessment. We can just gather the information for yourself and for your family members. As Ashley said, on both sides of the family, it's important. This information is important. So we can look at if you've had any breast issues that might put you at higher risk. We can look at what the family history is. We can look at there's a risk assessment called Tyrer-Cuzick that we use to determine what the lifetime risk is with and without taking genetic testing. And so we can get an idea of if your risk is 20% lifetime or greater to get breast cancer, what that regimen looks like as far as screening. So there are options. We can also look to see what your 5-year risk might be for breast cancer. And there are medications that can be taken that can reduce the risk for breast cancer by a significant amount, approximately 50%. And so there are definitely some options that we can offer without jumping to the test. And so I think that don't be afraid to come in and just talk. Just sharing information and sharing those feelings, sharing the emotions behind it. Genetic counselors can help with that too. And we can also, if there's more continued test or more continued regimen that you need to discuss those kinds of feelings, we can also make referrals for individuals that can help in that area, or sometimes spiritual advisors can be helpful as well in that process. So we can definitely look at other options as far as screening and what we might do to reduce the risk overall, besides doing testing.
Now, I will say, you know, in addition to some of those other stuff that we've touched on, I feel like the question I often get the most is, well, is genetic counseling and testing going to be expensive? How much is this going to cost me? So I know that answer can be very special, you know, highly specific depending on someone's insurance, but I was wondering if you could answer just generally how much, you know, this process costs, and if there are any assistance programs that you're aware of, you know, to help offset those costs for patients who are either lack health insurance or might be underinsured.
Yeah, that's a great question. And it is one that we get often because cost is important. And so we know that most insurances will cover testing if the family history is significant enough. But if an individual does not have insurance or doesn't want to use their insurance, then it is an option to pay out of pocket. And typically we can have testing available at the cost of about $250 or so. Also, some companies have a sliding scale based on income. And so that cost could be reduced to much lower, sometimes zero, depending on you know, what your income is. But certainly we can get it down pretty low in most cases and still be able to do testing for individuals who are underinsured or not insured. Genetic counseling, I'm sorry, I didn't answer that question. Genetic counseling the cost of genetic counseling depends on the state. So licensure for genetic counselors is one of the things that is still kind of being worked on around the country. but licensure can affect cost as well in some states. So some genetic counselors bill based on whether they're licensed or not, or based on whatever their model is in clinic. So perhaps you might have to see a medical oncologist for that appointment, and or a breast surgeon along with the genetic counselor. And there might be a cost accrued with that. Or there may be a facility fee, or there may be no cost. In some institutions, it doesn't cost anything to see a genetic counselor. So it just depends on where you're getting testing from. Also, I'll say that if you don't, or if you know someone that doesn't live near a place where they can access a genetic counselor in their city or nearby, there are certain companies that provide genetic counseling through video, so telemedicine visits, or phone visits as well. And so that's an option also to increase access.
Got it. And for an individual, so let's say an individual, they've gotten past their fears, they've done genetic testing, now they've gotten the results that they carry BRCA1 or 2 mutation. And as I always tell people, one of the most important parts of like undergoing testing is not just getting the information for you, it's getting the information to share with your family. And so I was just curious about some of the strategies or advice that you give to patients about how to share results of genetic testing, counseling and testing with family members.
Oftentimes if there is a positive result and you've seen a genetic counselor, they will provide you with a family letter and a copy of your results to share. And so that's one way to be able to share that information. The letter often includes what that mutation is associated with, or the alteration, the gene, the type of alteration, and what types of cancers those individuals might be at risk for. It's often up to a 50% chance that they may carry the mutation. And so providing that information can sometimes be helpful. Also, having them contact the genetic counselor, or calling them and having the genetic counselor on the phone with them, asking them to make an appointment. Those are options as well. And I often do that with my patients, just ask them to call their family member if they're having some concerns, and I'm happy to talk with them right then. Or they can bring them to an appointment with them, their next appointment. Also, I think having a family setting, so maybe going out to lunch, brunch, or breakfast together. It's often easier to share information over food.
Accurate.
And it's more relaxed. It's a more relaxed setting often as well. And I think just letting them know that you care about them, that you're sharing this information with them because you love them, because you want them to be able to be empowered to make their own decisions about their health, and learn this information before anything happens, ideally, so that they can be able to be screened early and offer preventative options. So I think some of those things are helpful. And I think sometimes just letting them kind of mull it over. We don't always have to have an answer right away. We don't always have to, be immediate with things. We can just provide the information, let them sit on it, let them, think about it a little bit, and perhaps they will come back and ask more questions and want to know about it in the future.
Got it. Well, I want to make sure we leave some time for questions. So I just have a couple more questions for our panel. Ashley, one of the things I wanted to touch on is, if you could share with us, sort of the journey that you described earlier, how that's impacted the way that you and your family approach health, and just shedding a little bit of light about how you have used your experience to help others. I know you are the author of a children's book, and I would love to hear a little bit more about that.
Absolutely. So first, I have to start off by saying this past February, my dad had genetic testing, which was really huge. It first and foremost, it provided me with some closure, because for over 14 years, I was really wondering who I inherited my mutation from. And of course, you would think because of my mother's side, the multiple cases on her side, that I inherited it from her. But my father is a prostate cancer survivor, and we know that prostate cancer is linked to a BRCA2 mutation. So I was able to educate him, talk with his doctor, advocate for him, and his results were negative. And so I was able to confirm that I did indeed inherit my mutation from my mother. And so this journey has really impacted me, and this is how I always really define it. Losing my mother was the defining moment of my life. But genetic counseling and genetic testing were the pivotal moments of my life. It changed the trajectory of the impact of this disease from my past to my present. It really helped to create a blueprint for my standard of care and my daughter's standard of care. And I always say this, breast cancer aggressively attacked 3 generations of women in my family. But through genetic testing, my girls and I can aggressively and preemptively attack breast cancer back. And then to your second question, I've really used this experience, really diving into the work of research advocacy. There was a time I didn't see myself in scientific research, but I've developed an intellectual curiosity and the constant quest for medical cures and health equity in African-American women continue to drive what I do. And I'm blessed to be able to do this work at a national and global level. And to your point, I did. In 2018, I authored a book, The Big Discovery. The Big Discovery serves as an educational tool to assist families and children navigating through a breast cancer journey. I remember asking my mother what was the most difficult, or what has been the most difficult part of your journey, and she would always say it was telling you and updating you on the unknown. And so this resource aims to help to facilitate one of the most difficult conversations a mother could have with her child. And it's to help them to understand the importance of early detection, genetic testing, and a breast cancer diagnosis. And so this is the first book of a series of children's books as it relates to their health.
That's awesome. So before we get into our question and answer, and for anyone who's been listening, if you haven't had an opportunity, if you have questions for our panelists, please put those into the chat. I just want to ask really quickly for the 3 of you, do you have any final thoughts or takeaway messages that you want to share?
So I'll go. I love the quote from Dr. Freeman, who was the he created the first patient navigation program in Harlem. He was a professor at Columbia, and went on to be the first director of the NCI Center for Cancer, Health and Disparities. And he said, people should not die from cancer because they are poor or because they're Black. This is more than a medical and scientific issue. This is a moral issue. And I quote him because when we talk about genetics and we talk about disparities in our family history, we have to really understand that I go back to that term bidirectional. We have, as patients, we have our work that we have to do. And as well as in the scientific and the medical community, work has to be done on both sides with addressing any type of biases or racism or any items of those nature. And then 2, it's rebuilding trust in the Black community, but also as patients being willing to take those steps with physicians and providers to get to that point, because our providers and our physicians, they're the experts. Our genetic counselors, they're the experts. And we need each other to be able to do this work and to continue to move forward, and to provide an equitable opportunity for everyone.
Yeah. Tiffany.
Oh, sorry. I totally agree with that, Ashley. And I think being able to just ask for testing, being able to ask for a referral, being educated and knowing that these options are available, because we know that based on research that oftentimes these referrals are not offered. Genetic testing is not offered to individuals of color. So I think that knowing that these options are available, knowing how to ask for them in the appointments, even if you don't actually want to do testing right then, you don't have to do testing right then. You can have a conversation about it. You can learn more about it. That's what we're here for, to help. And so knowing the education and knowing the options that are available really does help save lives. So I'm so grateful for opportunities like this to be able to share, because many people have no idea what a genetic counselor is or even exists. But we are here to help and to educate and to provide the knowledge and empowerment for individuals to know this information and to utilize it in their health and their decision making.
Yeah. Dr. Shah, anything you want to add before we go into Q&A? No pressure.
The only thing that I wanted to add is that, you know, these can be really, really difficult conversations to have. And it's definitely like, we have so many patients and family members who are reluctant to get testing. And one of the things that I have found is that part of the reluctance is fear, and almost just, you know, obviously part of it is fear. And I think a lot of our patients and their family members feel like the cards are already laid out. For sure, they know they have the mutation. And what I like to remind people is that there's a 50% chance when we're talking about, you know, the autosomal like the BRCA 1 and 2 mutations, there's like a 50% chance that we get this test and you're in the clear, and that you're going to be able to ease yourself of that burden. So I think, you know, it's important to just kind of remind people of that possibility, and as they kind of go into dealing with whether or not they want to get tested.
That was a really excellent discussion. And so actually, you know, talking about how these conversations are difficult, Tiffany, the first question is actually for you. Someone asked, how do I talk to my son who's in his 30s about getting tested, as he absolutely refuses to do anything about this? And Ashley and Dr. Shah, feel free to jump in as well. It was just directed at Tiffany.
Yeah, it's a really great question, and it's a really hard question. But I will say that, as Dr. Shah said, it's difficult to have these conversations, and oftentimes the issues are the emotional concerns behind testing. So it's fear. Most of the time it is. Do I really want to know this information? How is this going to impact me? How is this going to alter my care? That kind of thing. And the reality is that it's a 50% chance that you don't have this mutation. But if you do, learning that information is so important that you have it early. Because you do have options if you know it early on. And so if you learn it later on, then your options start to dwindle and go away. And so in talking with, you know, your son about this topic, I think being able to, if he will share that, and I know it's sometimes hard to get men to share their feelings, but if he will share that, why he has concerns about testing, if he's willing to talk to someone else. Sometimes, you know, our children don't want to listen to us. It takes other people to kind of impart it to them, and then they kind of understand it a bit more or understand where they're coming from. And so if he is willing to talk to someone else about it, and explore those feelings, explore those concerns, and then realizing that he has a good chance of not having the mutation as well. But again, if he does have it, then that gives him power. He's still young, and he still has a lot of options ahead of him. And the love behind it, you know, as mom, we love our children so much, and we want the very best for them, and we want to protect them. And so just letting him know that you just want to share this information with him, and him to learn this information, and it may, that it gives him more power. And it may even lift the burden. He won't have to think about it anymore. If he does, then he'll have the support that he needs to continue to move forward.
I'll just add to that I think sometimes there's this perception out there that males can't carry these mutations because these mutations are associated with female cancer risks. And so I don't think, you know, I've definitely encountered male patients or family members of patients who are male who didn't know until we discussed it that they could in fact carry the gene, they could in fact pass it down, and they could in fact develop cancers associated with the gene mutations. So sometimes kind of pointing that out dispels like a myth that some people may have, you know, a misconception that some patients might be under.
I would agree. I would also add, I think it's important to continue to put the information in front of him. And it's ultimately his decision. I feel it's so important that people know that genetic testing and counseling should be a choice, because that information that's delivered is life-changing. I have 2 daughters and I'm educating them now, but I know they're going to get to a point one day where they can make their own decision, and I cannot force them. I just hope that me educating them as young girls and into their teens and adulthood, that when they become of age, they would get testing so they can find out if they carry this mutation. I would not want to force them to do it, because I don't know if when that time comes, they're ready for that information. And we don't know what mental or emotional impact that would have on them. So continue to keep them educated, provide them resources, continue to have the conversation, and allow them to take that step on their own when the time is right.
And I would add, if they choose not to take that step, because it is a choice, and that's why we typically don't test children for these mutations, find peace with that and just continue to support them.
I think that was really great advice. I'm mindful of that time, but I want to try to hit 2 more questions. The first is directed for Ashley. Ashley, thank you for your powerful testimony. I'm curious to know how your message was received by your friends and family at the party you hosted. Did it inspire any of your other family members to get tested?
So that's a great question. So my immediate family, my dad and my close relatives knew almost 10 years ahead, because I found out when I was in my early 20s. So they already knew I was getting my increased surveillance. But what I was about to do was have that prophylactic procedure, and you can't hide that. And so what I needed to do was really educate, you know, those 2nd and 3rd degree relatives who maybe I hadn't really talked to, or I needed to remind them of my gene mutation, and my friends why I was getting this procedure. But it was really well received. There was a lot of questions. It really did have people think about their own family history. And just even now, people will come to me and ask me questions, and I try not to speak outside of the scope of my education, but I am very fortunate and blessed to have navigated through this system for so long that I can navigate them to the appropriate professionals that can help answer their questions. And so I believe it was well received. And again, I think it really helped people to think from a different lens, from a different perspective of not just maybe the maternal side or mom's side, but also considering dad's side. But then two, I'll go back to those rare, young, and multiple cancers, because those are really important, and they are also big red flags that should be considered and need to be addressed, especially when going to the doctor and having to report that family history.
And then the final question, and Tiffany, this is directed at you, but everyone feel free to jump in. With more Black women learning about breast cancer genetics, by the way, this is a problem with virtual. You can probably hear my fiance in the room. He's playing video games. I apologize. Tiffany, with more Black women learning about breast cancer genetics and family health history, more Black women are interested in genetic counseling and meeting with counselors who look like them. Is there a one-stop shop that connects Black genetic counselors, Black oncologists, and patients who might be interested in working with those healthcare professionals?
That is a great question. And unfortunately, I am not aware of any of those resources that connect us all together. But we are compiling a list of Black genetic counselors in the country, around the country, who can assist with cancer genetics and also other types of genetic conditions. And so I think that I will say that for genetic counseling, only about 1% of genetic counselors are Black or identify as Black or African American. And so there are about 5,300 genetic counselors in the country who are certified roughly, and only about 1% of those are Black, and fewer of those, of course, work in cancer genetics. So I think that we need to find ways to identify a pipeline that will help train more Black genetic counselors, African American genetic counselors, because it does mean a lot to be able to get information from someone who looks like you, someone you trust, someone who shares similar cultural values and that kind of thing. And so I think that we need to work on that. As far as oncologists, perhaps Dr. Shah can speak to that some. I did look up a little bit of information about that, but I'm not sure how recent it is, but perhaps Dr. Shah, you can speak to that.
Yeah, so it's a really great question. And I definitely agree that when there's a provider who looks like you, there's a sense of trust, there's a sense of comfort. And I think there's a lot of literature out there to support that as well. I think there are, professional organizations for Black female oncologists, Black oncologists in general, but I actually don't know of it. Those are kind of more professional organizations for kind of networking and collaboration amongst the providers. I actually don't know of any resources that help connect patients to a provider who has a certain background. I will say, I definitely, we not infrequently get requests from patients to see a particular provider who's, and there's patients who are more comfortable with females versus males. There's patients who are more comfortable with an Indian provider, a Black provider. And I think right now, the best way we have for making those referrals that I know of is just kind of on an individual basis.
Yeah.
May I just add to that? I think that's so important from the patient's perspective, where the patient feels comfortable, because those providers and those genetic counselors go on to empower those patients. And so it's definitely important. I know for me, I do have on my medical team, I do have Black doctors, but I also have a diverse group of doctors, and they're all amazing and all wonderful. And so I say all that to say, it's important that the patient feels comfortable with whoever they're interacting with, because that is where that education and that empowerment comes from, is from that collaborative conversation and from that relationship.
First off, I just want to say thank you to the three of you for sharing your time with us this evening. I just really quickly wanted to highlight a couple of resources and things based on our discussion. The first, I actually put a link into the chat. There's a platform called Health in Her Hue that connects Black women with Black providers, following up on our last question. I also want to direct the audience to the Black and BRCA initiative. The link to the website is in the chat. It's really meant to do programs like this and to provide culturally competent and tailored information to Black families about hereditary cancer. And one of the things that Vassar is doing this summer, because we were talking about issues of diversity in the workforce, is providing a summer internship this summer for underrepresented minorities to get them into genetic counseling. I would also encourage people to check out the Minority Genetic Counselors Network, as well as the Golden Initiative, which is working to I think educate individuals. So with that being said, thank you all so much. Again, go to the Vassar website. I think you can follow all of us on various social media, and just thank you again.